slides now. Okay, can you all see my slides, please?
You can see it, Laila.
Okay, great. So, Assalamu alaikum and good afternoon, everyone. Thank you so much. This is a great attendance. This is far beyond my expectations, and I'm very happy. Like so many people joined in. So, thank you for your support for our academic event. So eventually I ended up presenting STEMI equivalents, and the reason was like I couldn't find my slides last night. So we'll do STEMI equivalents today, and the next month we'll do the STEMI mimics. Now, by giving this talk, by far I'm not implying that I'm the ECG expert in the department, but because this is such a difficult decision when you're the shift captain and you're thrown an ECG while you're thinking about a million other things, and you need to decide whether this patient needs an urgent care or not. I thought that this is a great topic for everyone to sort of brush on our knowledge on ECGs. Okay. So by preparing this talk, I went to these 4 resources, which are excellent resources for ECGs. And if you guys want to read more about ECGs, like all these blogs are super interesting and made in a very simplified way to learn more about ECGs. And on top of these, not to forget, we also have the paper from our boss Hassan Qayoum on De Winter's ECG. So what are STEMI equivalents? Basically, these are patients with an acute myocardial infarction who don't really show the typical definition, who don't qualify for the definition of ST elevation MI on the ECGs. And there's a new concept of changing the name of STEMI into occlusive MI because this basically includes all these other presentations of ECGs who patients can benefit from urgent cath lab, but do not necessarily qualify the definition of a STEMI. Now, the definition of a STEMI is very limited to sort of have this ST elevation on 2 consecutive leads, but this definitely does not include a lot of other pathologies. Remember, patients without the ST elevation, they suffer double the mortality if they don't go for earlier perfusion. And ECG findings other than the ST elevation criteria can identify occlusive MI sooner and more accurately. Okay, so we'll go through different cases today. Some are easy, some are more complicated. And if anybody would like to volunteer from the audience to jump and give findings, otherwise, because of time, we will not wait for too long. So if anyone wants to sort of say what kind of pathology do you spot in this ECG, please go ahead. Just feel free to open your mic and speak.
So you have diffuse ST depressions, and you have ST elevation in AVR. This is left main STEMI.
All right, excellent. So this is a 49-year-old patient who presented with severe chest pain, and the ECG in front of you is showing that he's having ST elevation in AVR and V1 and diffuse ST depressions, okay? So across the entire ECG. Okay, so this is what we call the ST elevation in AVR, and it's due to subendocardial ischemia. Okay, so what does this mean? There's a differential diagnosis for this presentation, and patients can have either left anterior descending artery stenosis, they can have left main coronary artery stenosis, or severe triple vessel disease. But this ECG is also seen in patients who have hypoxia or hypotension, or basically a state of hypoperfusion. So not all of these ECGs mean the patient is having an acute MI. Now, there are papers who have looked at how many of these patients actually benefit from an early reperfusion. Like if you see this ECG, should you go and activate cath lab? And the answer was that only 10% of those patients had an occlusive lesion on the ECG. So this is debatable, and it's this kind of ECG needs early involvement of cardiology, and it will all depend on the presentation of our patients. And we'll see now several examples of such things. Okay, so this is a 70-year-old patient with 2 hours of chest pain, normal vital signs. And again, we can see this pattern that we have slightly elevated AVR, and we have T-wave inversions and sort of ST depressions, which are diffuse across the ECG. Okay, but this patient actually had hypertrophic cardiomyopathy on echo, and when he has done an angio, it was normal. Okay, so this pattern can be seen with patients with LVH. This is another example. This is a 75-year-old patient who presented with chest pain and shortness of breath. He was tachycardic, with setting at 85, and he had bilateral crackles. So he was having an acute heart failure. And again, you can see an AVR elevation, in ST elevation in AVR V1, and then you have ST depressions in V4, V6, lead 2 in inferior leads. Okay, so this is a patient with a CHF, but for this patient, cath lab was activated, and he did have LAD occlusion. Another example, 50-year-old patient, he presented with shortness of breath, nausea, and lightheadedness. He was tachycardic, his blood pressure, he was hypotensive, satting in 90s, his lungs were clear. Okay, so this patient was again showing the same pattern of AVR elevation, and there were ST depressions. So this patient was initiated for cath lab. He was given Plavix and aspirin, but then his hemoglobin came back at 3. And the massive transfusion protocol was activated. The patient actually had lower GI bleeding, and due to the hypoperfusive state, he had this pattern of ECG. Okay, so remember that the ST elevation in AVR with ST depressions can present in various conditions, not only an acute ischemic event. Okay, so this is important that always you involve the cardiology, and it will depend on what the patient presents with. So if the history and the presentation is convincing that this patient could be having an acute MI. Okay, so this is the next case, 70-year-old woman with an acute chest pain. What do you see in the ECG? All right, anyone would like to spot any findings?
So there are ST depressions in the anterior leads, and to a less extent in the lateral leads.
Okay, so you're right, and we see there are ST depressions from V1 all the way down to V4. Okay, is this again? Does this look like the previous ECGs where you have a diffuse ST depressions with AVR?
No.
No. Okay, so this is not a subendocardial ischemia, but this is actually a posterior MI. Okay, so if you see an ST depressions which are only from V1 to V4, so this is a posterior MI. Okay, now to diagnose posterior MI, we often go and do posterior ECG. But remember, if this comes back normal, that does not exclude presence of a STEMI. So only 53% of patients have 1 millimeter ST elevation on posterior leads, and 94% will have at least half a millimeter. Okay, so don't expect to see a massive ST elevation if you do the posterior ECG. Now, posterior MI has this has a very flat ST depression. Okay, so you remember that you can sit inside the posterior MI. Okay, so it has a horizontal ST depression, and it has a tall, broad R waves. Okay, now T waves can be upright, but later on they can be also inverted. Okay, this is another example of a posterior MI where it's very subtle, but you can see that you have ST depressions in V2, V3. Okay, this is a patient with an ST depressions again in V2, V1, V2, V3, and he has T wave inversions as well. This is associated with an inferior MI over here. And the way we used to learn in school is that if you turn the ECG upside down, okay, so if you look at it from behind, you will actually see the typical pattern, like a typical ST elevation of a V2. Okay, another example of a posterior MI where you see ST depressions V2, V3, V4. Okay, and in this patient, when posterior ECG was done, okay, you can only see a slight ST elevation in V5 and V6. Okay, so that's your posterior ECG. Okay, let's move on to something different. This is a 74-year-old patient who came with epigastric pain for 2 hours. Okay, so what do you guys see? Anyone from the audience other than Imad?
Not Imad, please. Can I play Dr. Laila?
Khalas, go ahead.
I see what looks like a sinus rhythm ECG, but more importantly, J point depression followed by hyperacute T waves in the anterior lead.
All right, so what would you call this ECG?
I think this is consistent with the D Winter pattern.
All right, perfect. Okay, so this is your ECG, Hassan. So this is exactly what you said. There's a peaked T waves all the way from starting in V1, V2, V3, V4, and V6, and you have ST depressions, like sloping ST depressions. Okay, and this is the classical D Winters T waves. So what is D Winters ECG? So basically, it's again, D Winters is equivalent to a STEMI, and it's present in 2% of LAD occlusions. You see these tall, prominent T waves that are symmetrical, upsloping ST segment, and usually you will not see ST elevation at the same time when you see a D Winters. Now remember, this ECG pattern can precede a STEMI or can be seen after. So you can see it before an ST elevation evolves, or you can also see it like after there has been an ST elevation, then the next ECG would be a D Winters. Okay. And remember, so D Winters is a sloping, so you can't sit on it, you will slide down. So D Winters definitely needs cath lab activation. This is an example from the case published by Dr. Hassan, where a patient presented with a very atypical chest pain, which was infrascapular and more movement for 1 week. This was an ECG done in the ambulance, and it showed a small, subtle ST elevations in V4, V5, and V6. But then when the ECG was repeated in the emergency room, it showed a D Winters waves in the areas where we saw an ST elevation before. Okay, and this is another example from our hospital where the D Winters is very subtle. Okay, so sometimes it's very subtle, and it's very easy to miss such ECGs, especially like when you're sitting in D19. Okay, this is a 55-year-old patient with a CABG, one history of chest pain, and this is the first ECG.
So I can see a normal sinus rhythm. I don't, and then a right, what seems to be a right bundle branch block. I can see AVL. There is T-wave inversion. T-wave inversion, is it? No, this is a Q. Maybe a subtle activation in AVL, but otherwise axis is normal. I don't see any prominent ST elevations.
Are there any ST depressions, Mariam?
Yeah, there is an V2.
All right.
And yeah, V2 mainly.
Perfect.
V3 maybe also, yeah.
Okay, so excellent. So this patient is having a right bundle branch block, and there are also ST depressions in V2, V3. So the question now is, does right bundle branch block hide acute ischemic changes? All right, so the answer is no. Okay, so this is a second ECG of the same patient, right bundle branch block, with now progressively evolving a posterior MI. And right bundle branch block does not hide any ischemic changes, because by definition RBB does not have an ST elevation or ST depression. Okay, this is unlike left bundle branch block, which we'll see soon. So if a patient has a right bundle branch block, this you can easily, or you can apply the same rules to identify an ST elevation or ST depression. And if the right bundle branch block is a new right bundle branch block, that actually means the patient is having worse prognosis. Okay, so this is a patient with a pacemaker. Okay, and she presented with an acute chest pain since 2 hours. Now, the problem with the pacemaker is the same problem that we have with the left bundle branch block, and that is that we already have an ST elevation with the paced rhythm. So how can you identify if the patient is having ischemic changes on an ECG that's paced? Any suggestions?
Can use Scarbosa criteria.
Okay, perfect. So we use Scarbosa criteria. Okay, and these are the same Scarbosa criteria that we apply to the left bundle branch block. And in this ECG, what we're looking for is any Scarbosa criteria. And this patient actually has, this patient actually has a concordant ST depression from V2, V3, V4, and V5. That means the ST segment is depressed and it is in the same direction as the QR complex. So the QRS is negative complex and the ST depression is in the same direction. Okay, so this patient has a positive Scarbosa criteria, which means there is an acute ischemic event. Okay, Scarbosa criteria help us identify an ST, an acute STEMI. Remember, they're not that sensitive. Okay, and the more criteria you have, the higher goes the sensitivity. Okay, the specificity. So if you have all three positive, your specificity is around 90% to diagnose an acute MI. And remember, only one lead needs to be positive to diagnose. So you don't have to have two consecutive leads. If one lead is positive for Scarbosa, that's your diagnosis for an acute ischemic event. Okay, so the three criteria are, is if you have, so by definition, LBBB has a disconcordance. That means the complex should go opposite of the ST segment. So if they are in concordance in the same direction, if you have an ST elevation or an ST depression, then that's a positive criteria. And the third criteria is that if you have an elevation which is out of proportion to the normal LBBB, so which is more than 5 millimeters, and in the modified Scarbosa, they said which is more than a quarter of the depth of the S wave. Okay, so if this distance is more than quarter of the S wave, okay, so that means it's out of proportion. It's too big to be just an LBBB. Okay, so this is an example of, again, left bundle branch block, and only in AVL we have a positive criteria because you have an ST elevation which is in concordance with the QRS complex. Another example, okay, over here, V3, V5, V6, ST elevation in concordance with the QRS complex. Okay, this is a 49-year-old patient. He has chest pain, and this is the first ECG done. And we know that his old ECGs were normal. So nothing much is going on in the first ECG. Okay, there's probably here a T-wave inversion. Okay, let's see. And there is also flattening of the ST segments in the inferior leads. Okay, now when the second ECG was done, patient started to be unstable. So patient started to have shortness of breath and was hypotensive. Okay, and as you can see over here that we have more ST depression with T-wave inversions in the inferior leads. You can argue that there's probably slight ST elevation over here, but definitely not a significant one. So what would you do with this patient? Is he for cath lab activation or no?
Yeah, definitely he's for cath lab activation because he's having shock and with acute ischemia. So this is a STEMI equivalent.
Okay, perfect. So this patient also has a small RBBB over here, which is new, which if you go to previous ECG was not there. Okay, so there is a new RBBB. There is an ST depressions and T-wave inversion. So it's by definition, it's a non-STEMI plus an RBBB, but this patient is hypotensive, okay? So remember that a non-STEMI with a patient who is unstable or has a new arrhythmia or acute heart failure or a new RBBB should also go to cath lab. Okay, I know that a lot of these cases are always debatable with our oncocardiologists, but then these are the patients we should push for, that they should go to cath lab. And the best thing is always to speak to the PCI team first rather than the cardiologist on call. Yeah, at least in my experience, most of the times when I speak to the cardiologist on call, they would rather wait for troponins and wait for a second troponins and then discuss it with someone, and then the management gets delayed. So it's best just to go ahead and speak to the PCI team directly. Okay, this is a 40-year-old patient. He was treated with hypertension and presented with a chest squeezing and shortness of breath and diaphoresis. This was 10 hours prior to his presentation, and it lasted 5 minutes, and now he's fine. Okay, so this was the first ECG. This is the patient's second ECG, and you can notice now that there is a slight change in the morphology of T-wave in lead 2, something that's very subtle, and often we see this and we don't really act upon it. Now this is third ECG, and as you can see that this T-wave became more clearly inverted, and V3 has inverted the T-wave as well. Okay, so this is a typical shape of Wellen syndrome. Wellen syndrome means that we have an unstable lesion in the coronaries, and it is highly specific for LAD stenosis. We have two types of Wellens, which is type A, where you see biphasic T waves, and type B, which is the more common, where you see inverted T waves. And as you can see, there would be a very slight ST segment elevation, which is usually less than 1 millimeters. What's interesting about this ECG is that you can see this ECG during the pain-free state, and troponin can be normal or just slightly raised. These patients might not need an urgent cath lab, but they definitely need to be admission and need early angiography. This is another example of Wellen syndrome. This is the type A, where you can see biphasic T waves in V1, V3, V2, V3, and V4. And here type B, where you can see inverted T waves in leads 1 all the way to V6. So from V1 to V4 is the most common type. You will most often see it in these leads, but sometimes it can go all the way to V6. Take-home messages. Remember this very nice summary of the ST segments that was shared with us, I think that originally by Dr. Danish on WhatsApp group, and then by Dr. Binyam, if I'm not wrong. Look at your patients first. If your patient looks in pain, he's pale, he's diaphoretic, then keep repeating ECGs, keep repeating serum troponin. So sometimes even the second troponin could be negative, but if you order a third one, it would be raised. Push for your patients to be admitted if they have high heart score, and if you're worried about them. Remember, the patient is in front of you. When you call the cardiologist on call and you describe the case, they only look at the ECG. They don't see the patient. If you feel this patient should go to cath lab, speak to PCI team first. These are two very good articles I would recommend you to read. This is the accuracy of occlusive MI ECG findings versus STEMI criteria. And the second one is the evolving ECG indications for emergent reperfusion. I'll be sharing both these articles on this way.